Good evening, respected teachers, senior colleagues, friends. Thankful to Raju sir, Himanshu, and Delhi team for this opportunity. I'll be speaking on instability case. Thank you for obliging me for giving me this opportunity today, and Sujit sir for adjusting it. So this is about a 28-year-old male patient who came IT professional, recurrent dislocation of shoulder since 8 to 9 times. And it was last episode was in 2022, and reduced in the hospital. And he, on evaluation, he had an IC score of 4, and the MRI showed a typical bank cut, 3-2 anto-inferior labral and a hill sash. Hill sash CT was done, and bone loss was 12% non-engaging. Just want to make it a little lively, just wanted to know the opinion of the house on this, because there's a lot of variability. Things have changed from like 5 years from now. So according to I would like to have the ARS on, what does the audience think is a critical value or critical bone loss?
Can we have the ARS? Is there ARS for this question there? Show of hands then.
So we need to put the ARS slide. Okay, we can do this by just show of hands. So how many for 25%? 20%? I think the majority of the house. 15%? 3, 4. 13.5?
Okay. So
1.
Yes.
Dip it.
Nice. So the majority is 20%. In my practice, I accept it as 15%, and I have a higher threshold for conversion. Now, in this scenario, what would we plan? So like it is 12% bone loss, it is bank card plus emplissage, or anything else. So again, I don't know if you can.
So how many for bank card? Only bank card?
It's an off track, less than 15%.
On track
No,
lesion.
on track. It's an on track. It's
on track lesion.
We can have ARS on this.
Just a bank card. On track, sir.
On track.
And bank card emplissage. Anything else? Because the last one is.
He's an IT professional, 28 years old.
Fine. Yes, sir. So now the next question was, so will IC score, or now Giovanni has come out as GTIMS score, will that make a difference in your score of more than 4? Will that make a difference in your approach? IC score of more than 4, will it make a difference in your approach?
Can we have ARS on this?
Chalu.
No, sir. He is not an athlete. He is an IT professional, and laxity scores are less, okay, like 2. So yes, okay. So GTMS score is important, more than 4. So here, the final option to want to ask was, so to summarize it, if he is a contact athlete, just to change the scenario a little bit, if he is a contact athlete, will your options change? And if he is a contact athlete, what would you advise? Is it a bank card, Latarjet, or a DAS? 12% bone loss, contact athlete. ARS, please.
Yep.
Can you please vote?
Yeah. This last one vote. I will not ask more. Yeah, it is equally divided. I can see that DAS has got the least takers, but the bank card and the Latarjet. So here, if again the last was, if he is a first-time dislocator contact athlete, so would you, or when would you operate? Number 5. So the next one, please.
So it's again a ARS.
ARS. The next one, please.
It's again bank card.
So here what we did is we went ahead, because considering that 12% bone loss, on track lesion, and in almost all my, actually in all my hill sash, I always do a emplissage, and considering that he had a bone loss of 12%, for above 15% I've done a Latarjet. And because anything between 15 and 10, I do a DAS. So went and did a DAS, and
So for your 12% bone loss, what method did you calculate it by?
best fit circle, Sugaya method.
Best fit.
Yes. So here, what we did was we went ahead and did a bank card starting from 6 o'clock position, prepared a labrum, and went and did a 6 o'clock anchor first, and plicated the inferior labrum. Then I came up slowly to the 5 o'clock position, and here I did a IGSL plication. I always do use a mattress there. There's a double-loaded tapes I used. One is taken for a mattress bite and the other for a simple to plicate up the labrum. Next, coming to, that is a 5 o'clock. So then I leave the 3 o'clock position free, and here, this particular point, I go to the rotator interval, do a release. A minimal release is required, and visualizing the subscap is also important there. Take a bite in the biceps. And we cut off the bicep from there, and then visualize it in the subacromial space. That's a subacromial space. We release it, and then take it out through the biceps port or an anterolateral port. You can take it off. And then here what we have done is we have taken the quadriceps tightrope, that is a fiber tack tightrope. It is we felt it was ideal for shuttling, and then after preparing it, I make a subscap, trans subscap port. How this is done was it is through we tend it with the Weisinger rod from posteriorly, visualize exactly where the cut is made in the subscap. We can through an anterolateral port, and then split it, and then shuttled it just like through the cannula. I have already used a ACL bead pin and shuttled it out, and this flips posteriorly, and then we pull it in. That is the biceps coming in, just checking the integrity, seeing if it is holding well, and then the remaining labrum is sutured back. So that's at the 3 o'clock position, so that I get a proper coverage and the bumper is maintained and the labrum is continuous. So, yeah. So this is what we did, and we got this published, and arthroscopy techniques, and now he was operated in March, okay, so it's like almost 5 months now, so his results are pretty good. So what we noticed was there is a slight recovery delay, because somehow he seemed to have little dyskinesis, and which we found little at 3 months still have not lifting up properly. We had to work little more on the scapula, and then in a matter of a month he picked up, and we had good results. He had a good lift, and yes, so that is the case. Now we could.
Did you do a ramplissage for this patient?
Yes, I did, sir.
What made you think of DAS here? Most of us will do only bank card and get out.
Yes, sir. Sir, looking at, when we look at the, not in everybody's practice, but when you look at the literature on the failure rates of bank cards, it is significant. There is a variability in data starting from 15% to almost 1/3 cases. Younger the patients, more recurrence rates. So when you look at that, so I felt that, so again, we have new data coming out. We're talking about 15% bone loss, 13.5% bone loss. So here, I felt that this, between 10 and 15%, I feel there is a void. Less than 10%, okay, yeah, soft tissue is pretty good. We can also use this technique in soft tissue insufficiencies, significant insufficiency, labral insufficiencies, and Sir was mentioning, like in an athlete. So all these kind of contact athlete, so I felt that this is an option. So here I did, because even though it was on track, but when I always do a remplissage, because in my results, I don't have a significant external tightness. It is there only in 10% patients of mine, which is acceptable. So giving up more stability, that's why I did this. Yes.
So what is the position of fixation of biceps on glenoid, and what is the position of the limb at that time when you're fixing it?
So the limb, so first what we did was, it was very interestingly, we did it in a cadaver. So cadaver dissection was very important for us, because especially this new technique. So we then went and first we inserted it. The shuttling was done through a M port, which we do for the latagai. But what we found was the conjoint tendon and the coracoid is coming in the way. So they modified into an I port, so which is for the long cannula, which is between the J and your M. So this we found as an ideal port and without affecting the nerve. So we did a arthroscopic dissection. We saw it in front where it was going in. So we found that that is the ideal port for entry. Then when we look at Philip Collins, so his original papers and other modification, what we find that everybody does it at the entry of the biceps at 3 o'clock position. Now question, why have they adapted the 3 o'clock? When we go back into the IGHL literature, we find that the IGHL 80% attachment starts around 3 to 5. That means it is actually centered around 3. Then maybe the other, why Philip Collins and others have already, they are doing at 3 o'clock is because the bone stock is better there. So here we are drilling with a 6 mm. So it is just like how we do an ACL. So we center it, through the cannula we center it, and we can use one of the ACL femur drills to hold it in place, and then we can drill it through. And then 15 mm, because if we look at the principles in ACL, how much is required for bone, for graft integration? 15 mm is required. So here we go up to 15 mm with a 6. So that is what we did. And then we did one more thing. We went posteriorly and dissected in the cadaver to find out that if it is, because if we are going from the I port, is the button flipping it in an awkward position, or is it coming out near the nerve? So we found that it was not. There was quite a bit of distance, almost at least a centimeter difference was there between the button and the nerve. So that's why we thought, and it is much simpler. So we have other alternatives we have done. For example, so we did a label reconstruction. So if I can show this video quickly. So
we
here
are running short of time, so
yeah,
we'll just like to conclude on the dash only.
Sure. So there's other options where like again fixation should be at 3. So there was a particular case we had a labral, severe labral insufficiency, and capsule application was tight. What we did was we pulled it 2 centimeter of the biceps. We pulled into the joint, fixed it at 3 o'clock position with a swive lock, and remaining we did a labral reconstruction. It was so beautiful because immediately the head centered. The tension on the capsule is gone, and we got a bumper effect as well. Then other simple way of doing it is, we don't have to even put a tightrope and all that. What we could do is subscap split, take the biceps out, fix it with a regular swive lock, 4.5, 4.75 swive lock, drill 6 mm, and then do an interference fit. That's even more simpler. So we felt that because here there's no hardware, it's only a button sitting there, we found that this was useful.